Now, as far as what to use, and again, I mentioned point of care testing, and point of care testing is just enzyme-linked testing. It's a dipstick, you dip it in the urine, and there's more sophisticated approaches to the enzyme-linked that are actually mechanized and automated in a machine, which actually we use in our large multidisciplinary practice, but most practices don't use that and don't have access to that, so they use the regular dipsticks. It's important to realize a number of things for this. First of all, there's not a shred of data, nothing in the literature about using point-of-care testing in chronic pain patients on opioid therapy, so that's the first point. Secondly, these have high sensitivity and low specificity, and they're designed that way because they were originally designed to pick up the use of illicit substances. So that, of course, is something that can be very helpful for us in treating our chronic pain patients. We clearly don't want them on illicits, so we can use point of care for that. But we just need to be aware of the weaknesses and the strengths of this particular form of testing. It's easy to do, it's cheap, again, high sensitivity, low specificity. You have to know that it won't cover some synthetic medications such as oxycodone, methadone, fentanyl. You can get dipsticks that will cover some of those things, and you just need to be aware that if you're just using the standard over-the-counter, not over-the-counter, but off-the-shelf dipsticks, if you're giving them oxycodone, it may not show up. So point-of-care testing we felt had a role, but the gas chromatography mass spec obviously is the gold standard, and I would use that for confirmation if the dipstick was not what I expected it to be.